I'm very grateful that I have this opportunity to share an important, my thoughts and the important material from my colleagues in front of such an awesome audience. But I am stressed, I will be honest with you, because it came on a short notice because of complications, which we will not go into. So I'm not sure that I will be able to present this very complex issue in a satisfying manner, but I will do my best. It is a complex issue. The behavioral and psychological symptoms in dementia. If you look at it from one glance, you could say that it's like a collection of things, of additions, in a condition that we understand more or less. So we understand dementia, and then there's some symptoms that can happen. So like there would be a field of mushrooms, and maybe a clear field of dementia, and then a mushroom pops up, which is a symptom, let's say agitation, and we pick up the mushroom, and then it's okay. But the thing is that the mushrooms are interconnected, and it usually happens that if we just pick up one mushroom, usually another one comes up in a different place. So I hope we will, together in this 20 minutes, we can find our way through a bit through the complexity. I would like to start out with a case, just to present the field. And the context is the hospital. This is very important. So the context is the hospital, psychiatric clinic. The people that we see them in the clinic. So this, in the sense, it sets out the context in the sense of severity of symptoms, and also in the severity of functioning. As you all know, if a person comes into the hospital, then the functionality is by definition less than, let's say, in other contexts. So an elderly man is brought into the hospital by police and an ambulance. He's very agitated. He speaks not very coherently, so on the border of coherence, but obviously has a lot of content. You can understand most of what he says, and much of what he says seems to be on the paranoid side. He talks about his daughter, who is against him, and he talks about being attacked physically. Later, when he comes to see the psychologist, you can still feel the agitation, but you can speak with him coherently. He is oriented all the time, and you get the following story: that he lost his wife a year ago, has been withdrawn for quite some time, not going out of the home, probably hasn't been eating properly or sleeping well, and what he minds a lot is that in this year, his daughter, who inherited half of the house from the mother, has started to adapt the upper part. The daughter doesn't live there, he lives alone in the house. And this adaptation for him was a big stress. He got more and more stressed about it, until one day he decided he's going to lock the house, and he's going to make the house as he wants it to be. The cognitive testing shows that he has some cognitive decline, but not much, mild. So memory function is okay, motor function more or less okay, but he has some problems in the abstract thought. He's not very good at very complex operations, although regular stuff, everyday stuff, he's good at. But abstract and maybe metacognition, so let's call that insight, are not that well. So, the other way to introduce this case is from a broader perspective. There are more and more people, elderly people, coming into the hospital. You can see this graph from year 28 to 29. So there's more and more old people, elderly people coming to the hospital. And the 30% of those people are people with dementia. The other are as follows: different psychiatric disorders. And this is the graph just for dementias from year 2000 to 2014. So the trend is there are more and more people coming in, elderly people into the hospital, and more get diagnosed with dementia. Why is this relevant in the context of symptoms of behavioral and psychological symptoms? Because as we can also follow from this case, there are a lot of people that come into the hospital primarily because of, let's call this, some psychological or behavioral symptom, but without the dementia. So, like this older man that I mentioned, so maybe agitation, delusion, but primarily not dementia. So this, we could say that we are getting maybe, this may seem, on one hand, you could say that there are more and more dementias, but on the other hand, you could also say that we are getting better and better at recognizing certain pictures, which at first seem as psychiatric pictures, in the context of dementia. Dementia is a syndrome, right? So it's a typical cluster of symptoms. And the symptoms are mainly in the cognitive and motor domain. So if you have a cluster of problems in memory, learning, language, motor function, perception, that is severe enough to be to affect everyday functioning, then you say dementia. But then there are the mushrooms, as I say. Things happen that are not in this, that do not belong into this syndrome, which we call behavioral and psychological symptoms, like verbal aggression, physical aggression, wandering, agitation, apathy, anxiety. They are, from the sense of functioning, they can be very debilitating, and they can prevent a lot of stress for the patient and or the caregiver. So, aggression, wandering, agitation, apathy, anxiety, you can imagine that these go directly into quality of life, everyday functioning. So they are important, a very important part in the diagnosis and treatment. But, and this is a problem, if we have, this is a syndrome, so this we understand as a certain pattern, but these are all singular symptoms. Why am I stressing this? I have another graph here. So here they are. There are many ways in which we can classify these symptoms. One is obvious into behavioral and psychological symptoms. So behavioral symptoms are the one that we can see with our own eyes, whether the patient is aggressive, is agitated, wanders around, maybe acts socially inappropriate. The psychological symptoms are the ones that we have to rely on verbal reports. So either the people suffering from dementia tells us, or maybe a carer tells us that he feels apathy, he feels anxiety, he's depressed, he understands things differently, maybe he sees things that he shouldn't see. And also here you can see there are many different kinds of classification, but here you can see, let's say, that most of these are symptoms, but some, let's say, depression, eating disorder, socially inappropriate behavior, okay, this maybe is not so well, but some are not symptoms. Let's say depression is a syndrome. So this is a more complex a more complex set of signs and symptoms. So what I'm trying to say here is that in the field of behavioral and psychological symptoms, although on the first glance it may seem like these are like isolated things that need to be taken care of, they are actually, in a way, this is the whole psychiatry, the whole problem of psychiatric diagnostic and treatment, but in the context of dementia. And this is important because, as I'm going to show you later on, these symptoms, so apathy, insomnia, anxiety, agitation, they can happen in many different syndromatic pictures. So in many different contexts of diseases, let's say. And is it just the fact that the person has the diagnosis of dementia, is that enough to say that, okay, then we will understand apathy as part of this dementia? Or is maybe apathy a part of some other, let's say, syndromatic state, like in the sense of comorbidity? So this can complicate diagnosis in a way. As you probably know, especially those who are more acquainted with psychiatric diagnostics, they like to talk about the biopsychosocial model. So when you do diagnosis, when you want to understand a certain disease state, a certain disorder, you have to understand it inside a given context of social functioning, a given context of personality, and a given context of his biology, constitution. And this, in the sense, goes the same for behavioral and psychological symptoms, but you have to add into this context that you have to understand, you have to add dementia. So I'm gonna try and think about these problems of putting into context along three different lines. So one is phenomenology versus etiology. So let's say that we find that a person is anxious, a person with dementia is anxious, right? There's a certain phenomenology to anxiety. So what type of experience this is, how it looks like for the person, where it happens, and etiology is what does it stem for? So what is the cause of this symptom, let's say, of anxiety? And a person can be anxious inside, let's say, a depressive disorder. If we take the person, the man from the introduction, he was also, a lot of time he was anxious. So we can understand this inside, let's say, a depression, or a certain type of anxiety, which is always present, always some fear. We can understand in the context, let's say, of a different syndrome. So if it's in the context, let's say, of depression, then we would also have other symptoms. So let's say like eating disorder, lack of will, volition, maybe psychomotor retardation, right? And if it's isolated, if we don't have that, then we can have it like as an isolated symptom, just anxiety. And then we can say maybe this anxiety is because just a certain part of the brain, which is responsible for the managing of dementia, for the managing of anxiety, has gone awry because of neurodegenerative disorders. So this is secondary. So neurodegenerative versus psychiatric. Is a given psychological and behavioral symptom that we see a part of the neurodegenerative process, or is it a part of some, let's say, more psychiatric disease? Another thing which is also very important clinically, at least, to take into account is what I like to call primary versus secondary. So a lot of these symptoms, anxiety, agitation, wandering, can have different underlying causes. So, let's say a person can be agitated, walk around a lot, maybe because it's primary, because this is something that he, like a lack of function, or maybe because there's some underlying somatic cause, let's say, that is causing this wandering. Maybe he has to go to the toilet. And why is this important? This is important because we will treat this symptom differently in different contexts. If he has to go to the toilet, then maybe we will show him the way to the toilet, and he won't wander anymore. But if the agitation has no, let's say, underlying cause in psychological behavioral science, then we will maybe treat it with something different. This is another way to categorize behavioral and psychological symptoms in the more phenomenological sense that correlates with psychiatric syndrome. So they may belong in the parapsychosis, suspicion, misidentification, delusions, hallucinations. So certain symptoms that we usually find inside psychotic disorders can also individually or in pairs present as part of the neurodegenerative process. Same in, let's say, mania, so affective disorders, depression, apathy, aggression.
We have 5 minutes left.
This slide, I think, shows well the problem of symptoms versus syndromes, because it shows how often certain types of psychological behavioral symptoms emerge during the course of the illness. And what you can see is that on the left side, this is before actual diagnosis, the symptoms are more complex, more complex units, like depression, paranoia, social withdrawal. When we go to the right hand sides, they go to more, let's say, primitive or simple behaviors like aggression, agitation, wandering, lack of inhibition. So, how do you manage these symptoms? Of course, important thing is diagnostic evaluation. So, not only that you have to know that it's dementia that we're talking about, you also have to know the main determinants of his somatic state, his neurologic state, his psychiatric state, and his cognitive functions. So it's very important to understand the level of which he can himself adapt to his environment, because in that way it will also be easier to foresee in what types of situation he will experience stress. So he will find it harder to adapt, and in situation when it's going to be harder to adapt, it's also more possible that we're going to see a rise of psychological and behavioral symptoms, those of the secondary type. This is a graph that shows the relation between diagnosed dementia, the number of diagnoses, and number of cases actually treated. As you can see, there are almost twice as much diagnosis as there are treatments of the symptoms. On one hand, you could say that this is, the clinics are not doing a good job finding it, but on the other hand, you can also say that maybe a lot of these symptoms, like we were talking about, all these symptoms are rooted in certain, let's say, intersubjective situations where they can also be taken care of. One hand. On the other hand, there's also a question of whether a psychological or behavioral symptom is something that ought to be treated per se. So let's say wandering, or maybe walking up and down, or some socially inappropriate behavior is just the occurrence of that type of behavior in a person, enough cause for us to treat it, right? And I think, like practically speaking, every symptom does serve also a certain cause. So let's say a certain effect. So if it's not overly disturbing to the environment, and it doesn't do damage to the person itself, it doesn't have to be treated. So treatment stems from diagnosis. If we understand the context, then we can also plan the treatment. An important part of treating these symptoms is, one, as we said, if we find somatic etiologies, we treat it. So infections, whatever, or psychiatric. But mostly what we do is help the context. We work with the context of the family and the patient to try to understand actually what is the pattern and the context in which these behaviors arise, and how to treat them. Because you can understand that a certain syndrome, a certain symptom is much less hard to deal with for the, let's say, for the family, if they can understand it in a different context. So if you say that, so he is, I don't know, he is walking up and down because he wants to annoy me, it's very different than if he's walking up and down because he has to go to the toilet and can't find his way to.
Would you please come to an end?
Mm-hmm. This is, to wrap it up, when we, in this case, to go back to the case in the beginning, of course you work from the principle of autonomy. So you want to talk it over, you include and you talk with the patient himself, but in many cases it takes, you have to include in your understanding his level of cognitive function, so to see where he can be autonomous, and include in these talks and treatment also the loved ones or the family. So in this case, the daughter, to understand the case, why it happened, and to move on from there. Okay. Thank you very much.